Well, good morning, everyone. How's the meeting been going so far? Good. Great. Let me tell you a little bit about the Blue Ribbon Commission report. How many folks have heard bits and pieces of the report so far? You know, over the last 10 years, the profession, and when I say the profession, I mean representatives from member service organizations like the American Osteopathic Association and various professional groups, board specialties, as well as the American Association of Colleges of Osteopathic Medicine have come together 3 times to talk about medical education, to make recommendations, and most of the times the recommendations go nowhere. I'm going to share your desk with you here because that coffee is hot. We've had 2 prior medical education summits, 1 and 2, and Medical Education Summit 3 was slated to start 2.5 years ago. And we decided that we weren't moving the ball when it came to issues related to the medical education summits in the past. So we wanted to change the name first and foremost. So we said, we're going to take on, this is going to be a Blue Ribbon Commission. It's going to be sponsored by both the American Osteopathic Association and the American Association of Colleges of Osteopathic Medicine. But also at the same time, there was an expectation. In the past, either organization, ACOM or AOA, could scuttle whatever recommendations they didn't like. The individual associations that sponsored the conferences felt that if we don't like what the recommendations are, we either will not endorse them or we'll make them go away. With the Blue Ribbon Commission, the commission decided and asked each of the organizations, AOA and ACOM, for the economic support, but an understanding that whatever came out of the commission would go forward without any editing from either organization. So that's a little bit of the history of the Blue Ribbon Commission report. Let me give you some more details at this point. This is a bit of a challenge since I know that there was more than one slide. I always have a plan B though. And the plan B is bringing my own slides. It is a good plan B. You see, I'm an anesthesiologist, and that's what anesthesiologists do. Plan A isn't working out. All right. I have a flash drive. Tara, I did email you those slides.
Yes, sir.
Okay. All right, this has more words on it, so this will be a little bit better. Okay, great. All right. Well, as I said before, this was a joint project from the American Osteopathic Association and the American Association of Colleges of Osteopathic Medicine. But we also had funding from the Josiah Macy Foundation. Josiah Macy Foundation is an independent organization in New York City It sponsors cutting-edge medical education, research, especially into advancements in medical education. They gave us roughly $35,000 to support the Commission's work. All right, the charge came in 2011. The AOA and ACOM identified an independent Blue Ribbon Commission for which myself and Boyd Boozer, who is the dean at Lakeville School, we were co-chairs. I was representing the American Association of Colleges of Osteopathic Medicine, and Dr. Boozer was representing the AOA. As I said before, the Blue Ribbon Commission came about to look at what we're doing in medical education today and what we could do differently in the future. But it was a response, not only an internal response to our profession, but also an external response from legislators and foundations, other stakeholders who were really looking to reform both undergraduate and graduate medical education. So the charge was this: we needed to assess the current U.S. healthcare system and its evolution. We were also asked to articulate a vision of a contemporary 21st century osteopathic physician so that we would be well positioned for the demands of this new century. In addition, we were asked to identify the competencies that a physician should possess in the future and to envision what this new educational pathway would look like to prepare osteopathic physicians, and for that matter, all physicians, for the 21st century. Big charge. All right, so where do the calls for reform come from? Macy Foundation had two major commissions themselves. One, who will provide primary care and how will they be trained? I was actually a member of that commission for that Macy report. And then revisiting medical school education mission at a time of expansion. That was in late 2008. I was also a part of that commission sponsored by the Macy Foundation. There was also a graduate medical education conference that Macy once again sponsored that looked at graduate medical education, how it's funded, how it's organized, and a lot of the financing that goes into graduate medical education. They made some recommendations. Part of those recommendations went to the Institute of Medicine, which is also weighing that issue right now. So the calls for reform also came from COGME, that's the Council on Graduate Medical Education. That's an independent organization that was originally empowered by Congress, but funded independently. They had a letter to both ACOM and AAMC. For those of you who aren't familiar with AAMC, it's the Association of American Medical Colleges. It's the organization that's akin to ACOM that represents the allopathic schools. So COGME, in about 2010, early 2011, sent a letter to both ACOM and AAMC asking both of our organizations to convene and pursue streamlining a conference that would look at streamlining physician education, how we could accelerate the time frame for physician education, how we could improve the quality of our medical education process, the development of competency-based evaluations rather than the time-based system we have now. Go to school for 4 years, pass a few tests, you're out. Could you take longer or shorter in a competency model? Absolutely, and that's what they asked us to look at. How could we also increase the number of physicians that were being trained with the resources we currently have? And how could we develop new approaches to team-based training? With team-based training, this calls to the Institute of Medicine's recommendation in 2001 in their conference, a report called Crossing the Quality Chasm. They talked about team-based care and team-based education. That means doctors, nurses, therapists, other health professionals, all training together and working together as teams. So COGME, this independent organization, reached out to both ACOM and AAMC and said, hey, do something. Do something. Come together, both your organizations, or do it independently. We had some discussions with AAMC, but as a much larger organization, they felt that they weren't ready to move forward to address some of these questions. Also, the end of 2011, 7 U.S. senators, most from west of the Mississippi, sent a letter to the Institute of Medicine. The Institute of Medicine is part of the National Academy of Science. National Academy of Science is a quasi-governmental agency that receives most of its funding from grants from the federal government, but is independent from the federal government. It was started under Abe Lincoln to answer some very, very difficult scientific questions, like how much gunpowder did you need in a cannon to figure out what the arc would be when you fire the cannonball? Also, how do you figure out how much alcohol is in liquor? Do you know why that question was important? Because that's how you figure out the tax on liquor is based on the percentage. So this is why the National Academy of Science was originally founded back during Abe Lincoln's administration. Institute of Medicine is the medical arm of the National Academy of Sciences, and the U.S. Senators asked the IOM to conduct an independent review of both the governance and financing of graduate medical education. How do we pay for graduate medical education? Why is it structured the way it is? How do we change that, and can we change it for the better? The committee was formed, and actually the original planning committee for the Institute of Medicine, I was the only dean at that time that was on that planning committee. We put together what the questions the committee needed to answer for the senators, and we identified members to serve on that committee. And the representative from the osteopathic profession, Barbara Ross Leahy from New York, is serving currently on that committee. All right, so the process. The process, Blue Ribbon Commission was established in the spring of 11, and the membership of the commission, there are roughly 24 on the commission itself, broadly represented osteopathic medicine, reflecting both the practice, community-based practice, professional organizations, the colleges of osteopathic medicine, the accreditation side, state licensure boards, and physicians in training. We had both student representation and resident representation on the commission. We also then went forward and we interviewed 19 key opinion leaders within medical education, not just on the osteopathic side, the allopathic side as well, not just undergraduate, but graduate, as well as continuing medical education experts. We also reviewed existing programs that were out there, some of the cutting-edge academic programs, both on the allopathic and osteopathic side. We reviewed numerous reports. We also looked for calls for reform where they were coming from. We had 4 face-to-face meetings, one in June 2011, one in January 2012, June 2012, and January 2013. We also had monthly steering committee meetings via telephone conference call, sometimes face-to-face. And we had an ongoing process of drafting and revising a report. As I said before, this is an independent commission, and the opinions are the recommendations of the commission themselves, and not the AOA or ACOM. These are the recommendations as they came out this spring. and we're starting to publish them now. We've been dragging our feet a little bit because the journal Health Affairs, which is a health policy journal, wanted to highlight our recommendations in an upcoming article, and did not want this to be out there until their publication came out. The recommendations: the creation of a new educational pathway that will produce board-eligible, practice-ready osteopathic physicians who possess the competencies needed for success in today's high-quality, high-value healthcare environment, such as accountable care organizations, patient-centered medical homes, and are ready to serve as leaders of the interprofessional healthcare team, nurses, therapists, other health professionals. The pathway consists of a competency-based integrated educational pathway with a seamless transition between undergraduate and graduate medical education. So the pathway would be both undergraduate and graduate medical education combined in a seamless transition. All right, the characteristics of the proposal. It's going to prepare osteopathic physicians for primary care practice and will incorporate traditional osteopathic practicing principles. It will consist of a continuous longitudinal educational experience. The undergraduate experience will be seamlessly integrated with a graduate medical education experience delivered predominantly in ambulatory settings. The proposal also calls for this pathway to be built upon a competency-based curriculum that's obviously centered on biomedical, behavioral, clinical sciences, as well as osteopathic primary care medical practice focus. It'll be a pathway where highly qualified students will be able to complete the program in as little as 5 years. So 5 years, undergraduate and graduate, with the product being a primary care physician. It will be co-managed by the Colleges of Osteopathic Medicine and the residency program partners. It will include a focus on healthcare delivery science, which will look at things such as principles of high quality, high value healthcare systems, healthcare team leadership, business principles, health policy, population health, health education, health information technology, quality assurance, and patient safety. So the end result of this pathway, upon completion of the pathway, the graduating physician will be ready for practice as a community-based comprehensive primary care physician and a leader of an interprofessional healthcare team. It's also understood that the graduates may elect to participate in additional specialty training. So this proposal, as it stands right now, is training a primary care physician in 5 years. Now look, I'm a subspecialty trained anesthesiologist and pain specialist. What the proposal looks at is, what if a certain group of students through an osteopathic pathway such as this became primary care physicians in 5 years? These folks could then go on, if you want to do neurosurgery or radiology, fine. But you're a board certified primary care physician first, and it would make you a better specialist going forward. One of the BRC members noted, as a profession, we would prepare better specialists if all physicians had a stronger foundation in primary care and population health. And I think that probably makes sense. And I think it would probably make our graduates much more competitive for various residencies, whether it's in the allopathic or osteopathic realm. All right, what are the challenges? Because we know it's, just saying something doesn't make it happen. Well, what are some of the challenges? Licensure. Obviously, the licensing boards have to be in alignment with the proposal. Accreditation. Accreditors such as COCA, AOA, ACGME, the accreditors have to recognize that this is a viable process and a viable pathway. Financial considerations. How is graduate medical education funded today? It's funded 96–97% of graduate medical education is funded how? Medicare program. The Medicare program funds most graduate medical education. So it's a proposal like this that the Institute of Medicine panel is looking at GME. I'm going to tell you just from some of the facts I hear leaking out of that panel that the IOM, the Institute of Medicine, is very excited about this proposal. So much so, they think that the other guys are asleep at the wheel, whereas we as a profession are looking at novel ways to educate the next generation of physicians. The regulatory environment, once again, that's something that needs to be in alignment with any new proposal in medical education, and public relations. We don't want, if this proposal goes forward, we don't want this to be seen as a doctor-like, that, oh, this is only 5 years from the beginning to the end. This must not be as well-trained a physician as someone that would go 7 years to become a primary care physician. So what we really would need to do if this program went forward is to make sure that the competency metrics are built into this, such that there's good proof that folks that graduate from this type of pathway are very competent physicians. Right now, we have a lot of knowledge-based assessments, both in school and for our licensing examination. We think that we're assessing competencies, but as my colleague Dr. Dubin in the back would say, we probably aren't. Are we asking the right questions in our examinations? And are we looking at the right assessment tools, even psychomotor skills, to make sure that we have competent physicians at the end of our training process? All right, so the next steps in the BRC process, we presented in July 2013 to the House of Delegates of the American Osteopathic Association, and it was uniformly accepted by the Board of Trustees and presented to the House of Delegates. In addition, we presented it to the Board of Deans from the American Association of Colleges of Osteopathic Medicine, who also endorsed this process going forward. So the proposal right now is that really, as a profession, and I guess I can't deny saying this because I'm being recorded right now, correct? Historically, we've always been a me too profession. That the other guys decide that medical school will be 4 years long, and it will be 2 years basic science sitting in a chair, 2 years in the hospital taking care of sick people, and that's what we do. We structure our graduate medical education in the same way. What if, as a profession, rather than being me too, we started to blaze a trail that perhaps the other guy follows in the future. And, you know, this is, we know that this proposal is out there. We know that it is a challenge to make all of the changes necessary to change the framework of medical education in this country today. But if you look at it, medical school is 4 years long. It's 2 years of basic science, 2 years of clinical science, and it was set up this way 100 years ago. And it was set up this way in 1911 after the Flexner Reform. And really things have changed very little since then. And you know what? things have changed a lot since then. So the question is, can we drive change? Can we as a profession drive change? Right now, 22% of medical students in the United States are osteopathic medical students. When I went to school, it was 5%, and God knows when Dr. Dubin went to school what it was. It must have been 2%, I don't know. But when I went to school, it was around 5% of medical students were osteopathic medical students. Right now, I won't say we're a force to be reckoned with, but we're a force that's shaping healthcare today. In fact, there's been a bit of a blending of the philosophies, the osteopathic philosophy, the allopathic philosophy. There's a lot of similarities, a lot of good things that we do that they have adopted. There's a lot of things that they have done that we've espoused to and adopted as well. It makes for an interesting time in medical education because we're answering a question that we didn't ask. The osteopathic profession didn't necessarily ask this. This was asked by the Institute of Medicine. This was asked by the Macy Foundation. This was asked by COGME. Various other community groups have asked us to define what medical education should be in the 21st century. So as I mentioned to you before, we have an article that was submitted to Health Affairs. It has been accepted for that journal, and it will be really the first major proposal of reforming medical education that's been published, I want to say, since the Flexner report. Maybe it's not as earth-shattering as that was, and I'm sure that we won't get 100 years from now folks talking about the Boozer and Hahn report from the Blue Ribbon Commission. But it may start people thinking about what medical education should look like in the future. The steering committee was made up of Dr. Boozer. John Crosby was the executive director of the American Osteopathic Association. Tyler Sinnott, who's vice president for education with ACOM. Myself, Karen Nichols, who's former president of the American Osteopathic Association and dean at Midwestern Chicago campus. Steve Shannon, who serves as the executive director and president of ACOM. That was the steering committee for the group. Our final title is Building the Future, Educating the 21st